Welcome to our second installment of our webinar series on With Everyone Else, Fundamentals of Community Inclusion and Participation and Implications for Coordinated Specialty Care. If you weren't here last week, my name is Liz Thomas, and I'm an assistant professor in the College of Public Health at Temple. And I'm also an investigator in the Temple University Collaborative on Community Inclusion that's directed by Dr. Mark Salzer. We are a national research and training center that's funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. And our goal, our mission is to promote community inclusion and participation among people who experience psychiatric disabilities. My work within the center focuses particularly on young adults with serious mental health conditions, including those in early intervention and psychosis program. And I'm joined today here by our wonderful co-facilitator, Bodie Bodenhammer, and Hannah Wells is providing tech support. I'll let them introduce themselves to you next.
Thanks, Liz. Hi, everyone. I'm Bodie. I'm a certified peer support specialist. I'm actually in North Carolina. I work at the Oasis First Episode Psychosis Clinic as the lead peer support specialist.
Hey everyone, I'm Hannah. I work with Liz at the Temple University Collaborative. Like she said, I'm here to help with any tech support. So if you have any issues during the webinar, feel free to send me a message.
Thanks, Hannah. All right, and just one other note before we get started. We are able to offer CEs for certain license holders in the state of Pennsylvania, and you can receive 2.75 CE credits if you attend all 3 of our webinar sessions and complete a course evaluation after the webinar has concluded. There's an email address, which I'll present in a future slide, that you'll need to email in order to get CE credit. All right, without further ado, we will move forward in the slides. Just a quick disclosure statement. Again, our funding comes from NIDLR, the National Institute on Disability, Independent Living, and Rehabilitation Research. They fall under the auspices of the Administration for Community Living. We're very grateful to them for providing support of our research and for making the contents of this presentation possible. So here is an agenda of what we're hoping to accomplish over the next hour. Last time we talked about what community inclusion is, what we mean by community participation, and why we feel those are critically important concepts. So today we're going to focus on describing some evidence-based fundamentals of community inclusion and participation, and provide some examples and ideas for how they can be put into practice within the context of coordinated specialty care and other mental health programs that serve young adults. And a lot of the ideas that we're going to be presenting today come from conversations that we've had with CSC providers or from the research that we've conducted with CSCs. So all of these are sort of real world examples. We do recognize that every program is different, so all of these ideas may not work for all programs, but really the idea and the goal here is to give you all some ideas for things that you could consider adding to your practices if you aren't already implementing them. So we'll talk through some fundamentals, implications, and ideas for CSCs. We do aim to make this an interactive webinar like we did last time. We'll have time for some discussion and breakout rooms, Q&A, and then we'll wrap up today with a preview of what's coming up next week and an overview of the technical assistance opportunity that we're offering. So we're now going to go through some fundamentals of community inclusion and participation. These are all described further in a document that I talked about last time called Well Together. I think Hannah is going to share that in the chat in case anybody wants to take a closer look at it. And we're also going to discuss, again, ideas for how these fundamentals can be put into practice. So fundamental 1 is that community inclusion is important. The idea behind this fundamental is that promoting community inclusion and participation isn't something that should be done as an afterthought. It's not something that should be done after other interventions have been implemented. But because of its critical importance, it's really something that we need to be targeting from the beginning of services. So in our last session, we provided 3 reasons why we believe community inclusion, community participation are critically important. One is that community integration is considered a legal right. 2, community participation is a medical necessity. And 3, we know that they are important, especially for young adult development and health. So just to recap, community integration is a right based on the Americans with Disabilities Act that was reinforced by the Supreme Court Olmstead decision in 1999. And then Olmstead set off a number of policy actions in the federal government from there that all really underscore the notion that community integration is a legal right. As we talked about last time, community participation is not only a right, but it's a medical necessity. And the argument for medical necessity comes from a number of theories and concepts, including the World Health Organization's International Classification of Functioning Disability in Health, or the ICF framework, where participation is viewed as a critical dimension of health and health functioning. Again, according to ICF, participation refers to involvement in any sort of social situation. So that could be being a student, going to church, synagogue, or mosque, voting, volunteering, anything that involves social interactions and meaningful activities. Finally, community participation during young adulthood is a way to test out one's interests and social roles and begin to solidify identity. People are exploring different things and interacting with different social groups. We also know that young adults consider a focus on life goals, such as interest in work and school, to be an engagement facilitator. So it's critically important to promote among young adults. And here are some ideas for ways that this fundamental can be put into practice within the context of coordinated specialty care and other programs that serve young people. First, everyone on the treatment team might be educated about the importance of community participation for physical and mental health reasons. So staff could attend trainings like this or engage in continuing education opportunities that really articulate the importance of community participation. So everyone's on the same page about this. Staff may also need specific trainings in how to incorporate a focus on community participation into their roles. For example, this might be a training on identifying barriers to community participation and how to assess participation interests. I think Bodhi wanted to say a bit more about this. Or was she, maybe you were going to talk about that second point, Bodhi, I think.
Yes, thank you. Sorry, I had to find my unmute button as usual. So the second implication for CSC, including this community inclusion and participation, they might need to prioritize community participation as a treatment target, like really making it concrete, just like you would for symptom management, relapse prevention, whatever. So sort of putting it logically into your targets for someone's treatment. A way to demonstrate that is by having a clear mission or policy statement, with your organization, with your team, with whatever, however it fits into your agency. It promotes community participation as one of the goals of your program. So that keeps it on people's minds.
Thanks, Bodhi. Yeah, really supports that accountability. The third point here is that the promotion of community participation could be a shared task among all members of the treatment team. Bodhi's going to talk a bit in a future slide about the specific role that peers can play, but we also share this belief that all team members can be promoting community participation in their own work and can actively be working on this with clients together. So Fundamental 2 specifies that community inclusion applies to everyone, not just specific individuals who we might think are ready, willing, and able to participate in the community. And the evidence for this comes from a couple of different areas. First, studies of people who have been in institutions for long periods of time, or studies of deinstitutionalization, have shown that people are able to participate later despite what people might have thought about them or predicted about them while they were an inpatient or while they were in an institution. We also have evidence from the psychiatric rehabilitation field around the fact that readiness, or whether we're able to predict one's readiness, is not a very evidence-based concept. And most of this evidence comes from the employment area, where we see that our ability as healthcare professionals to predict who is ready to work, or who has the skills or abilities to work, that's actually not a very good predictor of someone's employment outcomes or ability to be successful in the employment domain. So here are some practice implications for CSCs and other programs serving young adults. First, instead of trying to assess readiness, teams could use motivation and interest in participation as a criterion for providing support. This idea is consistent with practices that you might already be using, like the individual placement and support model of supported employment and education. It really involves, talking to people about their participation, interests, and goals, and then immediately connecting them to resources and supports to further help them explore and pursue their stated interests. So I think the next slide is on assessing participation interest. There are multiple ways that CSD programs could assess interest in different participation areas. One, you could use more formal focus group methods to gather people together and get input on the things that people are interested in doing. But you could also do this in more of an informal way as well. I think we heard from somebody who attended last time about how they have pizza and planning meetings where people get together in an informal way and talk together about things that they might be interested in doing, which could lead to activities that people could do together as well. We also, within the TU Collaborative, have developed a measure called the TUCP, the Temple University Community Participation Measure. So if you are interested in using more formal measures, this is a tool that we can offer you. And this is an example of what the measure looks like. It asks about the amount of participation that people have engaged in over the past 30 days in different areas. So for example, going to a library, entertaining family in your home, or visiting family or friends in your home. There is also a section on, do you do this activity enough, not enough, or too much? So that kind of gets at sufficiency or satisfaction with community participation. And then, is this activity important to you, yes or no? So you can get a sense for, what is most important to people, or what areas might they want to prioritize doing more. And this is a great tool that can be used over time as well to get a sense for whether the supports being provided are helping people do more of the things that they want to be doing. We've also heard from programs that they use what we're terming experiential support. So helping people find out what they're interested in doing by just exploring different areas. Going out to the library and getting information about different participation options, sporting events, maybe just walking through the neighborhood and seeing what's out there and what people might be interested in doing. We've also heard about team-based approaches, exploring different important domains and people's satisfaction with them in things like relationships, work and school, health, fun, spirituality, and then creating a plan as a team to help support the person around pursuing whatever their stated interests are. And I think Bodhi was going to add a bit about this team-based approach.
Yeah, I did want to add like a team-based approach really means like any member of the treatment team should be able to discuss these topics with like the participants in your program. But like peer support will probably begin to address these areas of interest early on because it's part of our role. If the young person isn't involved with peer support though, it's a good moment if anyone else on the team is able to have these conversations with them to connect them with a peer worker if they are interested in having some support towards these goals, because it can be intimidating to, get started again on community participation.
Thanks, Bodhi. Just a final note here. There are a number of resources that our collaborative has developed that might be useful to you all. So we encourage you to explore our website, tucollaborative.org, and check out the resources available there. Moving on to Fundamental 3. Fundamental 3 requires that we view CSE participants or individuals with lived experience as people and not simply as patients or clients or participants. I think Bodhi was going to take this one.
Yeah, this one's important to us, I guess, as peer workers. So we talk about patient and person schemas you guys talk about as part of your research. Patient schemas elicit beliefs about someone's impairments. They focus on deficits, on the diagnosis, on the symptoms, the medication, hospitalization history, incarceration history, etc. Like, you focus on not being able to work, not being able to finish school. We view people as patients because we want to solve these problems. Person schemas just means we view people with serious mental illness as people like everyone else who have, similar desires and interests and needs as far as, especially socially. Providers have very similar beliefs and attitudes about people with SMI as the general population. And this is important because of what they call the Pygmalion effect, the idea that expectations affect outcomes. So research on the Pygmalion effect in the education field has shown that, like a teacher, for example, their perceptions and expectations of their students actually turn out to predict the educational outcomes for those students. And we believe there's no reason why the same can't hold true in many areas, including mental health.
So very important to have a bigger picture of the person as we're trying to support them. And one way to ensure that we're viewing clients as people, like everyone else, is to perhaps reflect on our own experiences with community participation. We all know what it's like to try new things, to feel anxious, to maybe not know what we want to do with our careers, or know kind of what major to pursue if when we were young or a college student. And so if we can reflect on these experiences that we've had, we can kind of level the playing field by sharing those experiences with clients, including the things that have helped our participation and the things that have made it difficult or challenging to participate. And this includes, but isn't limited to, peer support specialists on the team. Again, because these are human experiences that we can all have, it can be beneficial for everyone to do some disclosure of their own experience as it relates to supporting individuals.
And this is the part where peer specialists are so important, because it's part of our role to change the perceptions about people who have that lived experience. I think clinicians who are very compassionate. In fact, I know that clinicians who are super compassionate can still see their clients as suffering persons who cannot help themselves. And it's understandable because, you know, we all have that moment where we cannot help ourselves, especially given hospitalization and experience of lived experience of psychosis and things like that. And the peer perspective and the language that peer specialists default to and that we prefer to use, hopefully it can help reveal some of the client's agency, their feelings, their point of view, their fears, which just in a more relatable way than psychosis can be communicated, I think. The less we focus on the pathology, the more we can imagine these participants at our programs as people with social lives and like roles in their community instead of just focusing on that patient schema I was talking about.
Bodhi. And as someone who does not identify as a person with lived experience and was trained as a clinician, I can say I think peer specialists can really enhance the culture of healthy self-disclosure on teams among coworkers and perhaps with clients or individuals as well.
Now I would like to hear from you guys. Just out of curiosity, please don't feel bad regardless of the answer, but I'm curious if you can start the poll. Thank you, Hannah. Does your team currently have a peer support specialist on their staff? This was literally just my morbid curiosity because it's been, some places have been doing peer support on CSE teams for a long time and some are starting to do it now, and it's really interesting. Feel free to opt out if you're not on like a team, but if you're, you know, maybe if you work, even if you're not on a team, if you have peers in your agency or something, you can also answer, I think.
It looks like most people have answered at this point.
Nice. Lots of yes. I like to see it. I like to see that it's increasing. Okay. If everything's done, Anna, and you want to close out that Zoom poll, thank you guys for answering. For the next one, I am happy to invite everyone. Like, thank you, John, for dropping it. You're a hybrid in your position in the chat. If you guys want to also use the chat or use the raise hand feature. My next question is, you know, how has the peer support role like influence your team's culture, how they perceive or work with young adult clients, do you think, just in your experience?
For this one, we welcome responses in the chat, or if it's easier, you can also just unmute yourself and share.
Well, I will go ahead and share then. So I'm Celeste. I'm in Odessa, Missouri. We're just starting our CSC FEP program. And I've been going out with our peer support specialist, a young man. I believe he's 23. And for me, it just really enriches my experience because I can talk to him about the experiences that the clients are talking about and kind of get his perspective on a different level. And that really helps me, I think, have a more complete or broader view of what's happening for the clients.
Thank you. That's awesome. I think we have Kaylin. I'm going to say that correctly. You raise your hand.
Yep, you got it. So I'm actually, Lauren dropped in the chat, and I'm actually the peer support on Lauren's team. Here, we're in Wentzville. We're the CSC team out in Wentzville for Compass Health. And I have found, kind of like Celeste was saying, I found that I've been able to connect with the clients, and kind of help get their perspective of like how to get them ready to see the clinical staff and make them more comfortable to see the clinical staff, if that makes sense.
Oh yeah, it does. we've been talking about having peer supports at our clinic be the ones who introduce folks to the services immediately.
Yeah.
Scott, I see you nodding. So yeah, it's the same principle. I think it helps get people comfortable with that clinical staff. I love that. Scott, you want to go ahead if you're next?
Yeah, hi, I'm Scott from Michigan, work with Navigate teams. We would have the peer go in like at the orientation meeting to get up to jump into that. And then I think our peer has done a nice job at really checking us on our language and how we're speaking and how we're like referencing things about people. And there's so things that are just so subtle that my biases and my background being a white man, like that just don't even cross my mind. And so I just really appreciate that. And I think it has more to do with like more of a horizontal structure where they feel like they can give us that feedback of like, Scott, you're way off. Like that's not even close. So I really appreciate that, and it's just so powerful that they can be a part of it.
That's amazing. I love to hear that. I wanted to look at some chat answers that were standing out. I love that you guys have folks you can refer, like youth houses and young adult shelters. We need more of those, I think, in my area. I love to see that. It's good to see some ACT folks here too. Bringing back valuable information I see from folks. Yeah, it's easier for some of them. You know, I can't tell you how many peers have told me they've never told anybody what they're about to tell me, which really feels like such a compliment to me that they feel safe and comfortable doing that. I did want to ask Angela, it says, you said you were having trouble like internal organizational barriers, particularly with inviting graduates of your program to join the team as a peer. I'm sorry to hear about that because actually, the other peer support on my team is a graduate of our program. And I think that they're in a really unique position to support people that they've literally done the same thing. And yeah, we run into a similar problem with the folks who apply. Not all of them have direct experience with first episode or hospitalization. And that's just the nature of the beast sometimes. I do have other peer supports I know who haven't had that direct experience, but have had really similar one, more similar than they thought. They're able to be trained and welcomed in too. But yeah, we all want to bias towards a direct connection. I'm sorry about the organizational barriers. That's not something that is easy to navigate, but it is really an ideal person for the position. Let me see. There's just lovely things in this chat. I love that you are all having peers and they're helping you think about it differently and get the perspective of your participants is really the most important thing. It's the easiest way for us, I think, as folks who want to be helpful to actually figure out what's helpful. There's a saying in peer support, it's like help is actually help. That's actually helpful. So I love seeing all of that. Thank you guys so much.
You all for your participation. So moving on to our next fundamental, fundamental 4 is the idea that we need to support self-determination and dignity of risk whenever possible. So self-determination is the idea that people with lived experience should have maximal opportunity to make decisions that affect their own lives, just like everyone else. We need to support people in doing the things that they want to do, not what we want them to do or what their parents want them to do, but really supporting their own self-determination to the degree possible. Obviously, this can get very tricky when our beliefs about what a person should do differs from what they want to do. But this is where dignity of risk comes in. And dignity of risk is a term that was coined by a disability rights activist, Robert Kursk, which refers to the right to make choices that affect one's own life, even when these choices could or do turn out to be mistakes, allowing individuals to learn from those mistakes along the way, just like everyone else. So many of us may have concerns about possible risks associated with community inclusion. For example, applying for a job or asking someone on a date could lead to rejection, and we might be concerned about people's ability to manage those experiences. But there are things that we can do, and Bodhi and I will talk about these here in a minute, to address risk head on versus trying to avoid it altogether. One thing to note here is that dignity of risk, by dignity of risk, we're not talking about life and death situations. We're really talking about giving people the dignity to take risks that they experience just living their lives. And that those with significant mental health issues should have the same opportunity to experience and learn from, just like everyone else.
So we're going to talk about some of the evidence around this, because this is a big tenet of peer support too. As people with SMI, especially younger individuals, they often express a desire to be involved in making decisions about their care, like because that's sort of the first thing that they're presented with once they join the team. It's like, or they become a participant, they have a lot of decisions that are potentially theirs, or maybe they wish were theirs to make, because they have to go to their clinic or see their providers frequently. So it's a big part of their life. And there's strong evidence in mental health that interventions that focus on promoting self-determination, which peer supports try to reinforce via supporting self-advocacy as much as possible, they're associated with good outcomes. And those are things like shared decision-making with the participant, working on their wellness goals, like using a tool like maybe a wellness recovery action plan or something, to help communicate more about what that looks like for them, what being well, or what their idea for their recovery is. They can envision it, and that helps us work with them. The benefits of participation also typically outweigh the risks, at least in the long run, because should there be something like they might consider a failure, something that didn't work out, they still have our unconditional support, and they have that support in dealing with the stress that might cause, or learning from there's an opportunity to learn from what happened and try again from a new perspective. So okay, I guess we'll go on to the ideas for CSCs. I mentioned wellness recovery action planning, which is sort of a holistic way of looking at yourself, what you are like when you're well, what are the warning signs when you're not doing well, and then planning ahead of time what to do should you end up in a situation where you're facing hospitalization, and even like a post-crisis evaluation, sort of thinking and reflecting on what happened and what you might want to do differently, or might want to ask others to do, especially since hospitalization often involves, removing your autonomy to make those decisions. Like, you can connect more to other people who are going to be supporting you. TMAPS is another tool that is like freely available, developed by On Track New York. That's similar. They're tools that help with developing personal medicines, a term I think Pat Deegan coined, which are activities and strategies that a person uses for their self-care. RAP, by the way, is proprietary, and TMAPS is in the public domain, just so you know, so feel free to look more into that. TMAPS, it's specifically, I'm a big fan of. It was developed by Jax McNamara and Sasha DeBrule, who wrote the peer support manual for On Track New York, to create a practical tool that embodied the peer wisdom found in our greater community, by augmenting the RAP approach, including a person's social determinants of health in the TMAPs, their family history, their personal history, their family of origin, their identity, culture, experiences of marginalization, and other just broader community-related contexts that affect their sense of self and affect their well-being. The expansive nature of TMAPS is part of why I like it. It's got a broad scope. It dovetails well with the notion of community inclusion. And personal medicines, coined by Pat Deegan, referring to those things that raise our self-esteem and make life worth living, her words. And her examples included things from the folks she was interviewing who were receiving treatment, asking them about, it was supposed to be a study about medication, but personal medicines became a huge theme. Things like fishing or meditating or exercising, having dinner with a friend, things like that. They can also be developed any number of other ways that a participant prefers. For example, on Pat Deegan's website, the article about personal medicines that she wrote includes a quote from a research study participant who said that doing math was one of his, quote, best mood stabilizers because it stimulated his intellectual processes, which I think is really lovely and shows the broadness of scope for what personal medicine can mean.
Yeah, that definitely would not be my personal medicine, doing math, but I'm glad it works for somebody. Just a note here about a couple of additional strategies or practices that CSCs can use. Psychiatric advanced directives and shared decision-making are also approaches that can help facilitate self-determination. We know a lot of programs are already using those. And this can greatly increase a person's sense of self-efficacy, which can translate to areas of life, including community participation. So it has broader implications beyond just making treatment related. Another strategy is doing with rather than doing for. So we really want to participate with people in pursuing the things that they want to do rather than trying to navigate challenges for them or problem solve for them. Really get them involved in exploring resources, learning information that they might need to participate and navigate challenges together. And then I also wanted to call attention to a specific resource that the collaborative has developed around managing risk. I think Hannah has put it in the chat, but it's great because it has a risk assessment tool for concerns or risks that people might anticipate as they're thinking about their community participation goals. And then what they can do ahead of time and how their treatment teams can partner with them ahead of time to figure out what supports they would need in place in case they were faced with these concerns. So encourage you all to check this out when you can. I think Bodhi wanted to give one final note on this slide.
Yes, I would. Increasing your participants' confidence and skills by facilitating their ability to have agency and take personal responsibility is critical, I feel, as this part of the process of recovery, because that agency would then inform their ability to reach out if they need something, connect with, participate with, and find their place in social environments and communities they are involved in, which goes well beyond the period that we are seeing them for.
Right. So fundamental 5 is the idea that multiple domains of mainstream life should be thought. And I think this one is especially important for us to remember in the context of coordinated specialty care, because we know most programs have an explicit focus on promoting education and employment due to the inclusion of supported education and employment services. And while these areas are certainly very important, we also need to focus on other areas of community participation that are meaningful to people and that have positive benefits for people. So for example, we also need to promote spiritual or religious participation if that's important to people, voting or other forms of civic engagement if people are interested in that area, dating and intimate relationships. Sometimes these topics are not so comfortable to talk about, but these are important areas of life that people may need support in. And then parenting, if some young folks are parents already and may need support in actively parenting their children and engaging in fun activities with their children. And then leisure and recreation, doing things for fun, exploring new hobbies. These are all critically important areas of participation to also focus on as well.
And then I might be a little redundant, but I do think peer specialists can't address many of these areas. But, you know, the whole team is involved and aware, hopefully, of what someone's sort of community inclusion and participation related goals are. We all can support them in that way. But, you know, as a peer support, I can go with them into the community. You know, I can help them sort of navigate where their resources are. We could look for ways that they could step into it. Then you have sort of the therapists who are maybe helping them reframe their anxieties about doing it. You have med management providers who are helping them if there's a medical component to helping them feel more at ease and more capable. You guys address that. I never could, you know, so there's a lot that we can all offer from our different roles that will just facilitate someone feeling capable and comfortable and supported.
So here are some examples, again, real world examples, things we've heard about from CSC programs, about some things that programs are doing to promote participation in other areas. For example, some programs have adulting or healthy relationships, or even dating workshops or groups. These groups sometimes involve role plays of dating skills, such as what to talk about on a first date. Some programs also provide some support with using dating apps or finding out what apps are available and helping people figure out how to use them safely. In terms of spirituality and religion, this is something that some programs explore at intake. So we know right from the start what people's interests are, and we can know, whether people might want support with doing more in that area. Some programs also help folks explore options, either by looking at online services that are available or checking out different religious spaces in their communities. And then some programs have a spirituality or religion specialist. If there's a member of the team who has an interest in that area or is engaged in that area, might make sense to dedicate a role for that person in supporting spirituality and religion. Or maybe programs would prefer to connect folks with community members, pastors, rabbis, etc., that have that expertise, so that programs don't have to have all the expertise in-house. In terms of civic engagement, there's lots of things that various programs do: NAMI walks, garden cleanup, or other kind of volunteer activities. We heard from one program that their young folks around Christmas time put together an activity book for young people who are on a local inpatient unit for them to have something to do over the holidays. And then some programs also support young people with getting registered to vote. We recognize, though, that keeping a pulse on what's going on in the community across all these different areas of community participation can be challenging. And so there are a number of things or some ideas here for what CSCs can do to support a focus on multiple domains of mainstream life. The first is to have an assessment process that captures participants' diverse interests. For example, some programs, again, ask at intake about things like spirituality and religion. Some organize activities like going to a sporting event or cooking to give people a chance to try out new things and figure out what they might like to do more of, and then connect with others who have mutual interests in those areas. Some programs have a dedicated working group or committee that works together to assess ongoing programmatic efforts to promote participation across a number of different areas. And some programs have specific kinds of support, like social skills. And I think Bodhi was going to talk a little bit more about that idea.
Oh, I just wanted to share it because we actually started providing these again. It had been a while since we had at my clinic social skills groups that I work with a lot of the folks who attended those groups, and I saw the skills that they were practicing and learning in those groups start to really apply across the board in some of their lives, advocating for themselves at school or work, or just feeling more comfortable calling up a friend and making time to go get coffee or something. So that stood out to me as a really good way to provide our folks with the basic skills that they need that can really apply across domains and promote their social engagement because they feel a little more comfortable trying it out.
Yeah, so providing support that translates to multiple things that people might want to do, for sure. So in the interest of time, we're actually going to skip the next fundamental and we'll cover this next time. I do want to give you all a chance to break out to have some discussion around the fundamentals that we've talked about. So for the purpose of this breakout room discussion, we're going to not discuss fundamental 6. We'll be discussing 1 through 5. And Bodhi, did you want to say a bit more about this activity?
Oh yeah, I just let me read the questions that you guys can talk about in your breakout rooms. It's which of the fundamentals 1 through 5 we talked about do you feel like your team is putting into practice well, or even routinely and effectively would be great. Even just trying would be interesting. And then what fundamentals would you like to focus on more in your work? You know, what do you have any ideas for specific actions that you could implement, and ways to do it, or what barriers do you think you might be running into and things like that? Like have a discussion to share what kind of things you are trying to do or would like to do. And then when you come back from your breakout room, you can tell someone to share what your group talked about. We would love to hear. But back in, welcome back. I hope you had some good chats. While you were talking, we were kind of short on time. So in order to get to hear what you guys were talking about, I would appreciate it if somebody from a group could share something that's working. And then either the same or another group could chime in with something that's presenting as a major challenge, like a barrier for these community participation things. And then anyone can drop any thoughts they have into the chat to elaborate on those. That would be great. So does anyone have anything really positive that they think they could share from their group discussion?
If it's okay, I'm just gonna unmute instead of raising my hand.
Go ahead.
We were discussing that we feel like that treating them as a person rather than a patient is really important, and that really is beneficial, treating people as a person and not their diagnosis, and that really helps you connect and build rapport.
Yeah, definitely. Love to hear that. Of course, I'm biased. And then in the case of something that's challenging for connecting to and working with these community participation goals, does anybody have something they can share?
I kind of thought about how groups kind of started dwindling because of COVID and everything. So I wish that, social groups would come back, because I feel like a social component is very huge, because I feel like, we meet people where they're at and everything, but a lot of people are like, I want to make friends, I want to know how to do all that stuff, and it's like, we can't, we could have a conversation, but it's not like I could be their friend or show them all of that. So I think that's a huge barrier that I've seen with a lot, is kind of that social component.
Yeah. People are getting tired of being stuck at home. Thank you guys so much. That is a big one. Liz, I know you needed to talk about our preview of session 3 and the TA opportunity. So you guys can feel free to drop all your thoughts in chat, but I'm going to let Liz take it from here.
Yeah, great. Yes, do feel free to continue to share any ideas that came up in the chat as we close things out. Just wanted to give a reminder about CEs. Again, certain license holders in the state of Pennsylvania are eligible to receive 2.75 credits. The email address that you need to email is here on this slide. Next week, we'll be together for our last session, in which we're going to cover the remainder of the fundamentals of community inclusion and participation, as well as additional ideas for practice. And then we also wanted to give a reminder about our technical assistance opportunity. Again, we're going to be selecting up to 5 CSCs to participate in technical assistance with us over the next year. This is free of charge. It's covered via our grant funding. Activities will be determined in collaboration with the selected programs, but they could include things like brainstorming with you about ideas you might want to put into practice, or giving feedback on new initiatives that you're considering, or even coming together in a learning community to allow for participating programs to support one another in these efforts. We will be disseminating an interest survey along with a webinar evaluation at the end of the webinar series, so you can indicate your interest in receiving technical assistance via that survey. Once again, we want to thank everyone for your participation today. I think we've learned some great things that you all are already doing, and some challenges that you're experiencing. And this TA opportunity could be a great way to talk about some of those challenges further and help you all navigate them. So glad everybody has invested the time and energy into having these discussions. Hopefully we'll see you all next week. Take care, everyone.
Bye, everyone. Thank you.